Hello, today we will discuss medical imaging in cardiovascular system, and here are the probable varieties of all imaging techniques. So on the first place, you want to always do ultrasonography. And when we are talking about ultrasonography, this is primarily B mode and M mode, and as an additional modality is Dopplerography. So both of them are following different aims. It have its own objectives, but it is hard to evaluate the heart condition and vessel condition and movement, like the blood flow movement, direction of it, and the intensity of the jet without each other. Next thing is radiographic techniques, and we are using actually a variety of them. This may be a radiographies like static images and fluoroscopy dynamic one, and CT scan since it is used X-rays as the beams. So we can use it into two subtypes. It may be plain and it may be enhancement with some enhancement. Next thing is magnetic resonance imaging. In some cases, we that is a necessity. For example, if we want to distinguish some tumors growing into the chamber or tumor growing into the pericardial sac. So CT scan may have some difficulties in distinguishing these pathologies. However, magnetic resonance imaging can enlighten the situation. And the last thing, but never the important one, this is nuclear imaging. So nuclear imaging, that is a technique which help us to understand primarily function and morphology subsequently. Well, and yeah, we have some variations, for example, like just scintigraphy when we are assessing the dynamic uptake of radiopharmaceuticals, or we can use some combinations such as nuclear, like PET, nuclear imaging PET CT or PET MRI. So let's speak about ultrasonographic techniques, and the first one is echocardiography and transthoracic echocardiography to be exact. And that is a routine heart study using ultrasound. So what are the actual benefits? It's a very fast technique that gives you both morphology and function. In case of morphology, we are evaluating different properties, and I try to divide some um, parts of the heart which you can evaluate. So we can see the chambers of heart, like we can see quantity of heart, volume of the heart, what is inside of the chamber. For example, that may be some blood clots or some, again, tumors which are growing into the chamber and can affect the shape of the chamber. We can evaluate walls like myocardial walls. We can understand how thick they are. If your patient has some dystrophia or some arrhythmias, you may see the thinning of the wall of the heart. Or on the opposite, if your patient have hypertrophy, you may see thickening of the heart. We may see some defects, and that is very useful if we talk about septal defect or some like defect of the myocardial wall after trauma or after rupture due to some reasons. We may assess bulbs, and that is a very common pathology, like valvular pathology after rheumatic fever. So we can check out the fibrous ring diameter, shape of it, some leaflet condition, whether or not we have incomplete closure because of sclerotic or like some calcifications of the leaflet. due to chronic and repetitive inflammation in them, or some hereditary pathologies, or maybe some papillary muscle problem, or some additional cords. So that is a actual like whole valve structure. We can assess pericardium as well. We can see the effusions. We can see the thickness of the sac. So yeah, that was about the morphology. Maybe later on you can add something on the actual like practice and discussion of the topic. So next one is function. We can understand the movement, and primarily we will speak about movement of the leaflets of the heart by using M mode, like motion mode. We can understand how myocardium and septi is moving, how the blood is moving by using Dopplerography. So transthoracic echocardiography, that is a very important technique as the screening and like in general. You can check very full information about the heart condition and the vessels condition. So how the patient should position himself. You can stop the video and read the information below. So here are some windows. These are called windows of CT, I mean of UFG. Windows, these are the points on the chest wall where we can place the ultrasonic probe or ultrasonic transducer. So you can see it right here. So patient is lying on his left side. You can see how we can touch the probe, we can press the probe into certain points of the chest to understand the condition of the heart. So first one is subcostal or epigastric 4-chamber window. So we can check it right here. So here is subcostal window. Then we have apical 4-chamber window. So you are moving a little bit onto the right side, and in the projection of the heart apex, we can place probe, and you can even see the direction of ultrasonic beam and try to understand what is the actual slice we are trying to achieve there. And then we have parasternal windows, like both long axis and short axis window. And on the left side of this slide, you can see how heart slide is going to look like on the UFG. So please stop this video, stop the slide right there, and try to simultaneously try to read and try to understand the projection. So this is how we will see heart on the UFG. Sometimes, yes, we can make some additional windows like supraclavicle window or suprasternal window for some vessels evaluation. Sometimes subcostal window right here, that is the only possible window because transthoracic imaging have its own limitations. So let's speak about first window. This is the apical view for chamber. This is how heart is going to look like. In USG, you always should understand that that is a layer technique, that is tomographic technique at the first place. And image will depend directly from how you will place ultrasonic transducer onto the patient's body. So right here, since we place transducer onto the apex of the heart, the upper parts of the image is going to be the ventricles. And here you are seeing the cavity of the left ventricle. Right there on the right side, you are seeing right ventricle, like right radiographic side, if you like to. Here is atrium. Here is septi. Here is valves. Please, for me, not put too much like speaking into this and explanation. Again, stop the video and try to read all the abbreviations right there. And here how we will look, and here how it will look like on the actual imaging. So let me play it once more. You can see how both of these valves are simultaneously opening and closed. You can see the contractions and rarefactions of the myocardium. And again, that is happening simultaneously, which is going to be the normal appearance of both morphology and function of the heart. Again, guys, please check out these abbreviations and what every of each of these letters are meaning. Next thing is subcostal window. As I said, that's sometimes the only option, and let me explain why. As you know, some structures in our body, they can affect ultrasonic beam into negative way in achieving the image. These are very dense structures, such as bones and calcification, and it may be some very airy, like gas-containing structure, since in both of these cases we doesn't have any distribution of the ultrasonic wave of the US wave further deeper into the thoracic cavity. So as an example, patient may have emphysema and patient may have enlargement of a lungs, and as a result you will have heart covered with lung tissue excessively, and that's why you cannot put the probe into the intercostal spaces, because these areas may be covered with lungs and lungs containing air, and air will dissipate ultrasonic beam. Or other example, if your patient had massive trauma of anterior thoracic wall and ribs, to be exactly, we may have excessive bone callus, which may kind of narrow and block intercostal spaces again, and we are not able to evaluate heart from this area. Or patient may have some like severe plaques on the pleural cavity. Sometimes it also may be an issue, but not that big of an issue as a emphysema or like pneumothorax or narrowed intercostal spaces and ribs deformities. Not like that, but it may be some issues. So sometimes epigastral or subcostal window, that is the only possible window. So problem here that we don't see apex that great. However, we can assess both chambers, valves, and septae. And yeah, we can see pericardium right there. So in understanding whether or not we have a fusion into pericardium, that is also a very good and viable option. Let's speak about parasternal lung axis, and in shortened, this is called plaques. So this is how ultrasonic probe is going to be placed. You can see this transducer. You can see how the beam is uh, irradiating kind of all the areas which are on the way. So here is anatomical view, and here is a basic, very basic scheme of what you may actually see. And here in the middle, you can see the image which we will achieve. So here, the first thing here which we may notice in the upper area, this is the cavity of the right ventricle. Uh, all cavities are going to look like anechoic with dorsal enhancement. Dorsal enhancement you can see right here, like right behind the cavity of the right ventricle, where we have intraventricular septi, or when we have this myocardium and pericardium. So you can see this slightest enhancement, like higher acoustic response from this area, because we have fluid inside of the chamber, and it is amplifies the USG wave. So next is left ventricle cavity, and right there you can see aortic valve, which is open right now, and aorta. Here on the right side, we are able to see left atrium. And here are two schemes. So here is mitral valve, it is closed, and aortic valve is open. And as you can see, the cavity of the left ventricle is kind of narrowed a little bit. So this is systole of left ventricle. And primarily when we will speak about whether it is a systole or diastole, that is about left ventricle in most of the cases. So if you will see like some notification systole, and you will see like this is right atrium or something, you should think about, okay, maybe it's a systole of the left ventricle. So here is diastole, and you are able to see how mitral valve right here is open and aortic valve is closed. So here are the leaflet of aortic valve. Here is anterior leaflet of mitral valve and posterior leaflet of the mitral valve, which are open, and blood is moving from atrium to the ventricle. You can see this papillary muscle, which is like in this image at this area. You can see how cavity of left ventricle is dilated, which means that this is diastole. So how you will place the probe, ultrasonic probe, from second up to fifth, it depends on the level. Intercostal space on the left side on parasternal line. And this is how B mode picture is going to look like with bigger explanation. So you can see a few additional structures right there, which are important to identify for the practical doctors. For the student, I don't think that you need to like know all of these abbreviation, but at least understand where are we. Like you may not notice that this is anterior leaflet or like posterior leaflet or like some aortic cusps. Like you don't actually need that much. I don't think that you need that in that big details. However, you should understand where is which cavity to understand like where are you actually, because it will be very helpful when we will speak about regurgitations and stenosis and other pathology of the valvular structures. So here is long axis again. These are the explanation, and here is a video. This is how it will look like. Guys, right there, this is a website, so you can check out the this type of videos on this site, or you can find them a lot on the YouTube. Parasternal short axis. This is the axis, like this is the level of aortic valve. You can see aortic valve right there, right in the middle, and you can see some very specific structures. Primarily, we are using this window for CT scan to understand the morphology and movement of aortic valve, but also it is very important to evaluate the right heart. So we can see the movement of tricuspid valve, we can understand how blood is moving from right atrium into the right ventricle right here. We can see pulmonary artery, we can understand the diameter of the pulmonary artery. So we can see the right ventricle out right there. So here is a bigger picture, but almost the same picture which you may see. Right there, you are also seeing this interatrial septum, which is useful if your patient have some um, intraarterial septal defect. So what else should we do? Not only we can make B study, like B mode study of the heart, but we actually can try to make color Doppler to understand how blood is moving from on the right heart. Whether or not we have stenosis and like pathological turbulent movement of the blood jet, or maybe we have some regurgitation from ventricle to the atrium if we have tricuspid insufficiency, or from pulmonary artery into the right ventricle. That is also an option. So we can see actually very, very different things. M-mode echocardiography, that is the other very informative and very important modality which helps to completely understand function of the heart. So what is it based on? It's based on the movement over time of some fixed areas of the heart. And sometimes we can use it to calculate some indicator. I don't find the kind of same scheme or diagram like in English. So here is, I will explain, right? This is thoracic wall. This is anterior wall of left ventricle. Then we have cavity. Then we have interventricular septi. And then we have, well, obviously we will have left ventricle. So this probe is placed to evaluate how the leaflets, anterior leaflet and posterior leaflet, are moving relatively to the thoracic wall right there. And we are not going to shift the position of ultrasonic probe in M mode. No, the probe is going to be located very static onto placed very static onto the thoracic wall, but we will um, try to understand how this actual part of the heart is moving over some time. And if you will switch your attention onto the right side of the slide, you will see this echoic linear zones. So first, the echoic linear zone is going to be connected with thoracic wall. And this thoracic wall is kind of wavy because this is how thoracic wall is going to look like over time while patient is breathing. Then you will see this isoechoic line. Again, it is moving because of contractions and rarefaction. This is wall of right ventricle. Then you will see cavity. Since cavity filled with blood, blood is a fluid, fluid is anechoic. So you will see black line right there. Again, it is repeating this overall wavy appearance because this is how heart is moving. So these are the movements of systole and diastole. Here is intraventricular septum. Then you have cavity of the left ventricle, sorry. And you can see movement this type of anterior leaflet, you can see it right there, and posterior leaflet of mitral valve. So what does it actually mean? When we have opening of the valve, this anterior leaflet is going to be closer to the probe, and posterior leaflet is going to be more distant from the probe. That's why you can see how anterior leaflet is moving upward and posterior leaflet is moving downward. That is what happens when you have diastole of the left ventricle. Then you have these small peaks. They are located on the one side. This happens while you have first part of the systole, when because of the pressure gradient, blood is moving kind of passively because of the gradient, because of very high pressure in the atrium and low pressure in the ventricle. Since the pressure, like because of the blood volume, are going to become more even, these leaflets became closer, like they are closing a little bit, but not completely closing, because then we have actual systole of the atrium. And as a result of this contraction, of this active pumping blood from atrium to the ventricle, you can see this second part of the movement of the heart. I mean, movement of the leaflet. So again, at some shorter distance, you are seeing how anterior leaflet again is going upward and posterior leaflet is going downward, which means that they are opening again. So left atrium myocardium can push all blood into the left ventricle. And as a result, we are having the closing right here of the leaflets. So here, actually, we are having systole of the left ventricle. So all blood, and by the movement of the ventricle and septum, you can even see how the cavity is becoming a little bit narrow again, because this is systole. So during systole, mitral valve is closed, and in the atrium we have the diastole, and the blood is flowing from pulmonary veins into left atrium right here, while we have this phase of the M mode, and aortic valve is open. So this M and W-like appearance of mitral valve, this is the normal. And here how it is going to look like on the actual B mode and M mode. So here is how we took the image, this image. So this is only one thin layer of the whole heart in the projection of mitral valve. And here is anterior and posterior leaflet of the mitral valve. Here is wall of right ventricle. This black line is cavity filled with blood. This is intraventricular septum. Here is cavity, the black one is the cavity of the left ventricle. Here is the movement M, movement of anterior leaflet, and W, movement of the posterior leaflet, which means here we have diastole, and here we have systole of the left ventricle. And right there you are able to see the left ventricle wall. Here it's like the depiction, but I don't think that you know that. If you didn't understand that completely, then try to read this by yourself or repeat what I just said. So Dopplerography, and this is the other modality of understanding speed and direction of the blood flow or the jet in the chambers of the heart and in the blood vessels. And Dopplerography is also maybe used easily in understanding, in evaluating peripheric vessels problems. We have actually many types of Doppler. So one of them, this is only one example, this is color Doppler, which can help us to determine direction of the blood flow. So towards to, not the sensor probe, it's going to be the red color, and away from the probe is going to be the blue color. So when we are doing this, what are the objectives of color Doppler? This is main objective here is detection of regurgitation, if we have some valvular pathology, or understanding whether we have shunts or defects. So here is again our favorite long axis parasternal view, and you can see this type of bluish color and reddish color. So don't miss that here we have left ventricle, I mean right ventricle, and in right ventricle we are having what type of blood? It is venous blood. So don't think that it is red one because it contains like arterial blood and blue one because it contains venous blood. No, no, it's not because of that. It's just the determination and understanding how flow is moving towards or other direction from the probe. Other technique which is making relatively rarely in cardiography, that is transepithelial echocardiography. Well, sometimes it is a necessary technique, especially if we want to understand how the atrium and especially left atrium are look like in patients who are unable to perform transthoracic echocardiography. But again, it has some limitations connected to it. So yeah, in patients who have atrial problems, we are like one of the options is to make transepithelial echocardiography. Problem here that because of the left main bronchi, we cannot understand the arc of aorta. So we should at least make like sternal notch, suprasternal notch imaging of the arc of aorta, because some pathologies such as aortic coarctation or aortic aneurysms are may be located very close to the arch of the aorta. So we should check this also. So what are the advantages and disadvantages? As I said, like can see auricle, we can see atrium, we can see the intraatrial septum, and yeah, actually you can stop this and read by yourself. Here is in the lower part we have disadvantage, and what I want to point on is that well, actually, yeah, we cannot see some specific structures, but also invasiveness to the patient. So not all patients can undergo through placing of endoscope into the esophagus, because it is very stressful. Patients may have some panic attacks during that, and especially cardiac patients who have like coronary disease or patients who have severe respiratory failure. In this case, we are not able to use that. We will try to make some other non-invasive techniques. And also some patients who have esophageal problems such as varices, if patients have portal hypertension and development of portocaval anastomosis, or patients have ulceration in the esophagus, or he have tumors, and we can damage tumor with our endoscope, and it may cause bleeding, and we can well, actually kill patients. So we should be very um, alert in understanding what are indications, what are contraindications, and how advantages will overpower the obvious disadvantages and the risks for each patient. Other option is stress echocardiography. As you understand, we are applying some additional loading onto the patient, and it may be either physical or um, medical, like drug-used stress. So what is the point here? Point here that we can check the images of ischemia, which is like ischemia occulta, like ischemia which is appearing only when you have some stress right here. So let's speak about radiographic techniques. On plain radiography, plain chest x-ray, you can see heart. It will be located in the middle of the thorax, a little bit shifted, not shifted, like dilated onto the left side. You can see the heart as a projection of the voluminous organ onto two-dimensional plane right there. And please don't think that here in the upper part we are having atriums, and in the lower part we have ventricles. No, it is not exactly true. So take your time, spend your time onto understanding and reading anatomy, because without it you couldn't understand what will happen on the x-ray. And here are some normal varieties of heart depending on the patient's constitution. You can see this patient is normasthenic, this patient is asthenic, and this patient is hypertonic. Sometimes you can see some shifting of position of the heart. So heart is located in the right hemithorax. However, the aorta is still located in the left hemithorax. So sometimes you can see this type of pathologies before you start USG. And well, obviously it is in patients like who have some active complaints. It is very important to do both radiography and USG. What else we may find on X-ray? Since you already discussed urinary system, you remember that the stones are visible on plain X-ray if they are X-ray positive or contain some calcium uh, inside of the structure. So right here is an example of calcification of pericardial sac. Patient may have trauma or may have some inflammation in the pericardium, and as a result you can see this linear calcification. Also you can see some wires in the projection of the sternum. So this patient underwent some operation, transthoracic operation, and this calcification may be due to pericarditis. Well, maybe right here we are seeing some slight calcification, or maybe he had open heart operation, surgery, and as a result we are having small amount of the blood which is then calcified. So also in cardiac patients you may see calcifications. Please check out this linear opacity which is following the uh, structure, following the site of aorta. So this patient Well, obviously his heart size is enlarged. It is kind of dilated more because of the left heart, like left ventricle and left atrium. However, this is not only the case. Patients have calcinosis of aorta. For example, if patient have atherosclerosis or patient have chronic inflammation like aortitis, and this patient have calcification of fibrotic ring of mitral valve. So sometimes you may notice these type of changes, these X-ray positive um, structures onto the heart shadow due to some checkups. And maybe you can find some very obvious mechanisms which can um, elongate patient's life. In terms of defibrillators, we should also check out how the wires are connected, because sometimes we may have dislocation, sometimes we may have injuries and ruptures of these wires, and if this apparatus is not working when it is necessary, again, patient may have myocardial infarction. As a homework, as an independent work, please check out cardiothoracic ratio, like basically cardiometry, and index MORE. Index MORE is used in understanding, in fast checking of pulmonary hypertension. So let's speak about X-ray anatomy. And in X-ray anatomy, you will speak about, first of all, projection of the heart. And here is how is heart going to be projected onto the chest. So please, again, spend your attention onto this. So what we may see, we can divide it into two cardiac borders. Here is going to be the midline. We have left cardiac border, which consists of few bulges of the heart, and we have right cardiac border. So please check out. Here is the midline. Here is left hemithorax and left cardiac border. Here is right cardiac border. So I think I should draw this maybe. So sometimes we are not able to see um, first bulge of the heart on the left side. So if it's slightly visible, it is okay. But sometimes we may see this very significant bulge of the first arc. In this case, we will think about pathology. So if it stands out from vertebrae for a few millimeters, up to 5 millimeters, this is fine. So sometimes we have two arch or two bulges or mogules. This is the symptom, either or. In the literature, I think you will find this definition more often. So some authors say that there is two bulges, some others say that this is one bulge. So here, number 2, look right there, is right atrium. And yes, exactly, right cardiac border is formed by right atrium. You will ask me, why this border is not actual superior cava vein? Well, it is not, because superior cava vein have thinner structure compared to aorta. That's why we may notice SVT only if patients have congestive failure. Let's speak about the left border of heart. Here is a first bulge or first mogule. So with which structure it is formed? It is formed with this structure. This structure is called aortic arc or arch, right there. Then we have second bulge, right here. So this second bulge is formed by pulmonary trunk, and directly from pulmonary trunk you are able to see pulmonary artery, which divides into two branches, upper lobe and lower lobe. And yes, here is pulmonary artery left pulmonary artery right there, and it is divided into upper lobe artery and lower lobe artery right there. Let me please clear that. Then we have third bulge of heart. The projection is here. As you can see, this is auricle, not the atrium exactly, but only auricle of left atrium, which means that in normal conditions, we are not able to see auricle of left atrium. Only when we have increased pressure, increased blood volume in the left atrium, which leads to hypertension and dilatation of left atrium. So these two bulges of heart are called waist of heart. Okay, please remember that. And the last thing, that is the easiest thing, in the left border we are able to see fourth bulge right there. It is formed by left ventricle. You can see the apex of the heart. Sometimes we have fifth module of heart right there. It is triangular shape. It has a smaller intensity than the heart, and it's formed by pericardial sac pad. So please don't think, like sometimes patients have very huge pericardial sac right there, and when they are measuring, like doctors measuring cardiothoracic ratio, they may count this fat as a left ventricle. So please don't make this type of mistakes. So patient is not need to underwent through some additional imaging techniques to understand. Here is a lateral view, so pause the video and try to check this out by yourself. This is how heart it looks like on the lateral view, and here is the same patient but overlapping with the actual image of the heart. So stop the video and read that. When we are talking about radiography, cardiovascular system imaging is unimaginable, I think, without contrast studies. And for CVS, we are using solutions and iodine-based solutions. So they are very successful in understanding the cavity properties and also dynamics of the blood flow and the lumen, like both vascular and cardiac pathology. And it will give us understanding of where is cavity and where is wall. I will explain later on one CT scan. This is angiocardiography. You can try to understand which parts of the heart we try to evaluate, and as you can see, we introduce contrast from the upper extremities. Then we went into the clavicle area. Then we went to the right border of the heart, which means that here is subclavian vein, here is superior cava vein, and right here is right atrium. And here is this type of butterfly-like appearance. This is right ventricle. And from the right ventricle, we have movement of the blood into pulmonary artery. And you can see how pulmonary trunk, then both pulmonary arteries are having this contrast. And yeah, this is how contrast looks like on the pulmonary arteries in the pulmonary circle, and then you are seeing contrast in the left ventricle and in the left heart. So you can subsequently make examination of how contrast and blood filled with contrast, not filled, but dyed with contrast is moving in from heart to the patient's body. This is some specific techniques. This is aortography and this is coronarography. Both are used catheters since we administer contrast to the left heart. We administer through the femoral artery in this case. And you can see this catheter in the projection of bulbous of aorta, and we can see arc, we can see right, I forgot how this artery is named in English, so please forgive me, that was a long day. Here is left common carotid artery, and this is subclavian. On the right image, you are able to see how we administer contrast exactly into the coronary arteries, which is also very informative if patients have CAT. CT scan. CT scan, if we are talking about like plain CT scan, have limited use in understanding like primary heart pathology. So in most cases, we are making first image is CT scan without any contrast, and then we are making some sequences of contrast studies in most cases, because without it we can't differentiate between cavity and lumen and walls. We can make densitometry, so we can measure the density of some structures. We can make three-dimensional reconstruction, and CT scan is crucial for evaluation lung condition because some patients may have pulmonary edema as a complication of cardiac problems. So this is how CT scan without any contrast is going to be look like, and this is soft tissue window, so you find some explanation about structures. You can see this calcified plaque, atherosclerotic plaque in the coronary artery, which is in this case the reason for ischemic disease of the heart. However, if you will look exactly, for example, here onto aorta, you cannot distinguish where is aortic wall and where is a cavity of aorta. I mean the lumen of aorta, because in this window, without any contrast, we can't understand where is what, because everything have kind of the same imaging. However, you can see surrounding structures like surrounding connective fatty tissue filling the heart right there, as well as myocardium. So this is how it will look like on CT scan, and in the left heart we are able to see this X-ray positive contrast right here, and you are seeing the smallest defect in the filling in the cavity of the left ventricle. So in this case we may suspect some left ventricular myocardial infarction. This is in the projection of this plaque. So this maybe. So we may suspect this type of pathology. This is magnetic resonance imaging. So it gives us better understanding and better visualization of walls and cavities. So check out please this image. You can see these darker walls which have less intense magnetic resonance signal. However, the cavities filled with blood will have higher magnetic signal from it. And in terms of pathology, like read this, stop the video and read this. In terms of pathology, we have some mass primarily located in the cavity of left ventricle, which in diastole of left ventricle is moving from atrium to the ventricle. So this was benign tumor of the septi, which called myxoma. And this tumor is mimicking mitral stenosis. So magnetic resonance imaging give us very good information and give us a huge clue in understanding why this patient have pulmonary edema. Not because he have valvular pathology, but because he have relatively big tumor filled cavity of the atrium. Other very important technique is nuclear imaging. So in cardiovascular system, we can make two types. First one is perfusion scintigraphy with thallium chloride or technetium tetraphosphine. So like perfusion means how well your tissue is blood flowing, yeah, like how efficient the vascularization. Let me reflate myself, how efficient vascularization is in the myocardium. Plus, we can make stress to identify some hidden areas of ischemia. Because some patients have, uh, how does it call, cardiac angina only when they have stress. And also, we may make myocardial examination if patients have infarction with technetium, but not tetraphosphine as here, but pertechnetate. And they will give us different depiction. So what we may see right here. Scintigraphy, first of all, that is a technique where we understanding how tissues are vascularized with radiopharmaceutical. Radiopharmaceutical, that is a compound which contains of radioactive element and some transport ligand. So, depending on this ligand, we may have different sensitivity and different affinity of some tissues to some specific radiopharmaceuticals. However, heart is not that specific, so it will light up every time when we use scintigraphy. So let's speak about perfusion scintigraphy. It is very important when we want to see myocardial infarction or ischemia at very early stages. And it is also used in the tandem with coronarography CT scan or coronarography and PET CT, either or some of it. So check this out. This is how heart is moving, like left ventricle is moving and perfuse during the rest. However, if you have stress, your patient has low uptake of radiopharmaceuticals, especially in this spot right there in the anterior wall. Here is the explanation. So anterior wall of the left ventricle during the stress have reduced perfusion, which means that patients have ischemia. Same is right here, but we have two defects right here. Here is the apex, which one is affected, and we should think about the prognosis for the patient. This is how scintigraphy without PET, without CT scan, is going to be look like. So you will see this heart and these small flashes of gamma radiation emitted from radioactive element. So then we catch these flashes with gamma chamber. This is the opposite imaging. This is scintigraphy of myocardial infarction with pertechnetate, technetium pertechnetate, and it is selectively accumulate in the necrotic cardiomyocytes, which means that this increased uptake. Here we had cold focus, or right here, or low uptake. Here in perfusion scintigraphy, that is going to be pathology. However, if we are using different radiopharmaceutical per technitate right here, only damaged cardiomyocytes are accumulate these radiopharmaceuticals. And you can see some smaller spots of accumulation dispersed in the left ventricle right here. So in this case, we are saying that hot spot or high uptake of radiopharmaceutical is relevant, not relevant, but visualizes us, give us the information about actual area of infarction, and also some hidden areas of ischemia. And this type of scintigraphy is used as assessing dynamics, like when we want to understand and when we want to make follow-up. So after 8 or 10 days, so yeah, first thing first, that we shouldn't give this pertechnetate without 10 minimum, 10-24 hours after infarction. So in early infarction, only perfusion scintigraphy. After 1 day, we can start to make myocardial infarction scintigraphy, pertechnetate scintigraphy. And we can see this visualization of radiopharmaceuticals up to 8 to 10 days. And if we are making repeat radiopharmaceutical study right here, pertechnetate study, then if it is accumulated later, like after that, then it is meaning that your treatment is not working, so we should check out other options of more successful treatment, because patients have this hidden ischemia, which may lead to infarction at 1 day. So here, how coronary artery disease looks like. First thing, one of the most informative technique right there is coronarography, and you can see either narrowing or filling defect or amputation sign, either some of them. You may notice this representation on coronarography. However, on CT scan, and this CT scan was made with contrast, you can see how first pass, which is catched. First pass of the contrast is not filling completely this wall, which means that we may have some areas of myocardial infarction in the left ventricle, in the anterior wall. And yet this patient has myocardial infarction, since also you are seeing these ground glass opacities, bilateral, symmetrical, located in the posterior areas of the lungs, which means that patient developing some respiratory failure because of edema, pulmonary edema. What we may see on echocardiography, we may notice akinesia or hypokinesia of the wall and decreased cardiac output. Sometimes if we have rupture of either coronary artery or wall of myocardium, we may see fluid in the pericardium. And in nuclear imaging, as I said earlier, it will depend on what type of radiopharmaceutical you will use. It is either low or high uptake. That is going to be also the homework for the next class. So you should check out configuration of heart. Overall, we have 3 configurations. Sometimes we have this type of 4th configuration, but this is kind of somewhere close to trapezoid shape, globular heart. And also we may have local bulge enlargement. So your homework is to read about pathologies such as mitral regurgitation and stenosis, aortic regurgitation and stenosis, and tricuspid, let's speak, regurgitation. You should understand hemodynamics, like what you may see on the like what will happen in the patient heart and overall in the circles, and how we will evaluate patient condition using different imaging techniques. So that is all for today. Thanks for attention.